As part of our antibiotic series, we're now going to talk about drugs that weaken the bacterial cell wall. First, we're going to talk about penicillin. The penicillins are practically ideal antibiotics because they are active against a variety of bacteria and their direct toxicity is low. Allergic reactions are the principal adverse effects. Owing to their safety and efficacy, the penicillins are widely prescribed. Penicillins work by weakening the cell wall, causing bacteria to take up excessive water and then rupture. They're active only against bacteria undergoing growth and division, and they are bactericidal. Now, there is some bacterial resistance, and the mechanism of resistance is the inability of penicillins to reach their target and inactivation of penicillins by bacterial enzymes. There are many different penicillins, and as a result, they require their own classification system. The most useful classification of penicillins is based on antimicrobial spectrum. When classified this way, the penicillins fall into four major groups. The first is narrow-spectrum penicillins that are penicillinase sensitive. The second is narrow-spectrum penicillins that are penicillinase resistant. The third is broad-spectrum penicillins, and the fourth is extended-spectrum penicillins. This is a really nice table that describes the four different classes of penicillins, the drugs within each, and how they're used. This table reveals the specific antibiotic, the brand name, route of administration, dosing intervals an hour, and then also adult and child dosing. As you can see, there are a few different IV dosings of penicillins to be aware of. Penicillins are the most common cause of drug allergies. Between 0.4 and 7% of patients who receive a penicillin experience an allergic reaction. Severity can range from a minor rash to life-threatening anaphylaxis. Because of the cross-sensitivity, patients allergic to one penicillin should be considered allergic to all other penicillins. In addition, a few patients, about 1%, display a cross-sensitivity to cephalosporins. Penicillin reactions are classified as immediate, accelerated, and delayed. Immediate reactions occur 2 to 30 minutes after the drug administration. Accelerated reactions occur within 1 to 72 hours, and delayed reactions occur within days to weeks. Immediate and accelerated reactions are mediated by the IgE antibodies. Anaphylaxis is an immediate hypersensitivity reaction mediated by IgE. Anaphylactic reactions occur more frequently with penicillins than any other drug. There are some drug interactions to be aware of. For some infections, penicillins are used in combination with an immunoglycosides, such as gentamicin. By weakening the cell wall, the penicillin facilitates access of the immunoglycoside to its intracellular site of action, thereby increasing bactericidal effects. Unfortunately, when penicillins are present in high concentrations, they can interact chemically with immunoglycosides and thereby inactivate the immunoglycoside. Accordingly, penicillins and immunoglycosides should never be mixed in the same IV solution. Rather, they should be administered separately. Once a penicillin has been diluted in the body fluids, the potential for inactivating the immunoglycoside is minimal. There are other antibiotic drug interactions to be aware of that are also listed on this slide. This table shows penicillin use across different age groups. They are safe in infants and children. They are most likely safe in pregnant and breastfeeding women, but doses should be adjusted in adults with renal dysfunction. Now we're going to talk about the four different classifications of penicillins and dive into each one. First, we're going to talk about penicillin V. Penicillin V is also known as penicillin VK and is similar to penicillin G in most respects. The principal difference is acid stability. Penicillin V is stable in stomach acid, whereas penicillin G is not. Because of its acid stability, penicillin V has replaced penicillin G for oral therapy. Penicillin V may be taken with meals. Next, we're going to talk about penicillinase-resistant penicillins. Now, by altering the penicillin side chain, pharmaceutical chemists have created a group of penicillins that are highly resistant to inactivation by beta-lactamase. In the United States, there are 3 such drugs available. These agents have narrow antimicrobial spectrum and are used only against penicillinase-producing strains of Staphylococci. Moving on to broad-spectrum penicillins, there's actually only 2 of these, ampicillin and amoxicillin. Both have the same antimicrobial spectrum as penicillin G, plus an increased activity against certain gram-negative bacilli. We're going to spend a little bit more time talking about ampicillin and amoxicillin because they're so widely used in clinical settings. Ampicillin drug is useful on a few different bacterium, including all the ones listed on the slide. The side effects are just rash and diarrhea, and it may be administered orally or IV. Now, amoxicillin is also similar to ampicillin in structure and actions. The drugs differ primarily in acid stability, amoxicillin being more acid stable. When the two are administered orally in equal doses, blood levels of amoxicillin are greater. Accordingly, when oral therapy is indicated, amoxicillin is preferred. Side effects of amoxicillin are milder diarrhea when compared to that of ampicillin, perhaps because less amoxicillin remains unabsorbed in the intestines. We'll talk about dosing here in a little bit, but amoxicillin is also available in a fixed dose combination with clavulanic acid. This is a nice slide that goes over dosing of ampicillin and amoxicillin for both PO and IV. When talking about extended spectrum penicillins, there's actually one available, piperacillin, which we will spend a little bit more time talking about. Now, the antimicrobial spectrum of piperacillin includes organisms listed below, which are quite a few. Piperacillin has a broad antimicrobial spectrum. However, the drug is penicillinase sensitive. Piperacillin is highly active against P. aeruginosa, its principal target. Piperacillin can cause bleeding secondary to disrupting platelet function, which is an important side effect to note. The drug is acid labile and hence must be administered parenterally, usually by the IV route. There's also a combination that we'll talk about a little bit later, marked as Zosyn. Penicillins can be combined with a beta-lactamase inhibitor. There are different combinations listed here, including Unison, Augmentin, and Zosyn. Because Zosyn is used so often, I did want to spend just a minute talking about the dosing for Zosyn. Traditional infusion method, usually over 30 minutes, is IV. For mild to moderate infections, you want to do 3.375 grams every 6 hours. For severe infections, you do 4.4 grams every 6 to 8 hours. And then for coverage of Pseudomonas aeruginosa, you want to do 4.5 grams every 6 hours, with a usual maximum dose of 18 grams a day. It's okay to use in pregnancy, and side effects include GI disturbances and skin rashes. Listed on this slide are the different fixed doses for Zosyn, and in the notes section I also have Zosyn dosing for different indications. Listed here are different prescribing considerations for penicillins that you should review prior to prescribing any penicillin. I want to take a moment and pause and just talk about Staph aureus and how it relates to penicillins and MRSA. So going way back to the 1940s, penicillin was introduced. At that time, all strains of Staph aureus were sensitive. In 1960, just 20 years later, 80% of Staph aureus isolates in hospital displayed penicillin resistance. Now, penicillin derivative, methicillin, was developed, but resistant to actions of beta-lactamase. Now we have penicillin-resistant Staph aureus, or MRSA, which has a unique mechanism of resistance. It produces PBPs with a low affinity for penicillins and all other beta-lactam antibiotics. MRSA developed this ability by acquiring genes that code for low affinity PBPs in other bacteria. Now we're going to talk about cephalosporins, which also weaken bacterial cell wall. Like the penicillins, the drugs discussed here are inhibitors of cell wall synthesis. By disrupting the cell wall, these drugs produce bacterial lysis and death. The cephalosporins are beta-lactam antibiotics similar in structure and actions to the penicillins. These drugs are bactericidal, often resistant to beta-lactamases, and active against a broad spectrum of pathogens. Their toxicity is low. Because of these attributes, the cephalosporins are popular therapeutic agents and constitute our most widely used group of antibiotics. There are different generations, the first through fifth generation, that we'll talk about further. Cephalosporins are generally well tolerated and constitute one of our safest group of antimicrobial drugs. Serious adverse effects are rare. Hypersensitivity reactions are the most frequent adverse effects. Macular-papular rash that develops several days after the onset of treatment is most common. There are severe immediate reactions, including bronchospasm and anaphylaxis, but again, these are rare. The cephalosporins can be grouped into 5 generations, as alluded to earlier, based on the order of their introduction to clinical use. The generations differ significantly with respect to antimicrobial spectrum and susceptibility to beta-lactamases. In general, as we progress from the first generation agents to the fifth generation agents, there's 1, increasing activity against gram-negative bacteria and anaerobes, 2, increasing resistance to destruction by beta-lactamases, and 3, increasing ability to reach the CSF, or the cerebral spinal fluid. The table here discusses the use of different cephalosporins according to their generation. The therapeutic role of the cephalosporins is continually evolving as these new agents are introduced and as more experience is gained with the older ones. Only general recommendations are listed here. The table here shows pharmacokinetics of the cephalosporins. Because of poor absorption from the GI tract, many cephalosporins must be administered parenterally or via IM or IV. Of the cephalosporins used in the United States, only 10% can be administered by mouth. Of these, only 1 can actually be administered orally and by injection. This table reveals first-generation cephalosporins, the trade name, routes, dosing intervals and hours, and adult and child dosing. This table reveals the second-generation cephalosporins, the trade names, routes, dosing intervals and hours, and adult and children dosing. The table here reveals the third-generation cephalosporins, the trade names, routes, dosing intervals and hours, and adult and child dosing. This table reveals the fourth-generation cephalosporins, the trade names, routes, dosing and intervals and hours, and the adult and child dosing. Lastly, this table reveals the fifth-generation cephalosporins, the trade names, routes, dosing intervals and hours, and child and adult dosing. This slide discusses key prescribing information for cephalosporins, and the one thing I want to point out is that cephalosporins are contraindicated for patients with a history of allergic reactions to cephalosporins or severe reactions to penicillins. All cephalosporins can also promote C. diff infection. Therefore, you would instruct the patient to let you know if they have any increase in stool frequency. Now we're going to talk about carbapenems, which also weaken the bacterial cell wall. Carbapenems are beta-lactam antibiotics that have a very broad antimicrobial spectrum, although none is active against MRSA. 4 carbapenems are available, and they're listed here. With all 4, administration is perennial. To delay emergence of resistance, these drugs should be reversed for patients who cannot be treated with a more narrow-spectrum agent. This slide discusses the drug trade names of carbapenems, the dosing, which you know it's all IV, interval dosing in hours, and normal dosings. One carbapenem that we're going to spend time talking about is imipenem. It's active against most bacterial pathogens, including organisms resistant to other antibiotics. It's highly active against gram-positive cocci and most gram-negative cocci and bacilli. This drug is effective for serious infections, and the broad antimicrobial spectrum gives imipenem special utility for antimicrobial therapy of mixed infections. It is the most effective beta-lactam antibiotic for use against anaerobic bacteria, and it's given intravenously. There are few adverse effects and interactions. Generally, it's very well tolerated, but there have been GI effects, including nausea, vomiting, and diarrhea that have been seen. Above is key prescribing information for carbapenems. Most importantly, patients using valproate to control seizures should not be placed on imipenem. Additionally, you want to monitor for indications of antimicrobial effects, including reduction in fever, pain, and edema. Lastly, dosages should be reduced in patients with renal impairment. This slide discusses patient information specific to age, specifically cephalosporins and carbapenems, and the others that we will talk about. Now, as you can see, third-generation cephalosporins are okay in infants, cephalosporins are okay in children and pregnant women, and dosages should be adjusted in older adults. There are other classes of drugs that we're going to discuss briefly, including vancomycin, telavosin, aztreonam, and fosfomycin. Vancomycin is the most widely used antibiotics in the U.S. hospitals. Principal indications are for C. diff, MRSA infection, and the treatment of serious infections with susceptible organisms in patients allergic to penicillins. The major toxicity is renal failure. Now, unlike most other drugs discussed here, vancomycin does not contain a beta-lactam ring. Now, as in the case of the beta-lactam antibiotics, vancomycin inhibits cell wall synthesis, and therefore promotes bacterial lysis and death. However, in contrast to the beta-lactams, vancomycin does not interact with the PBPs. Instead, it disrupts cell walls by binding to molecules that serve as precursors for cell wall biosynthesis. Vancomycin is active only against gram-positive bacteria. The drug is especially active against Staph aureus and Staphylococcus epidermis, including strains of both species that are methicillin resistant. Vancomycin should be reserved for serious infections. This agent is the drug of choice, again, for infections caused by MRSA or Staph epidermis. Most strains of these bacteria are still sensitive to vancomycin. The major toxicity is renal failure, as stated earlier. Risk is dose-related and increased by concurrent use of other nephrotoxic drugs. To minimize risk, trough serum levels of vancomycin should be no greater than needed. If significant kidney damage develops, as indicated by a 50% increase in serum creatinine level, vancomycin dosage should be reduced. Ototoxicity is another side effect, and it rarely develops and is usually reversible, but risk is increased with prolonged treatment, renal impairment, and concurrent use of other ototoxic drugs. Now, rapid infusion of vancomycin can cause constellation of disturbing effects, including flushing, rash, pruritus, urticaria, tachycardia, and hypotension. This is collectively known as red man syndrome. These effects, which may result from release of histamine, can usually be avoided by infusing vancomycin slowly over 60 minutes. Thrombophlebitis is also common. The reaction can be minimized by administering vancomycin in dilute solution. Rarely, vancomycin causes immune-mediated thrombocytopenia. And then lastly, patients allergic to penicillins do not show any cross-reactivity with vancomycin. This slide right here discusses the treatment alternatives for C. diff infection. And as you can see, for initial episodes, vancomycin is still the preferred drug therapy choice. Key prescribing information for providers specific to vancomycin is listed above. One thing I want to point out is, again, it's for the treatment of serious infections, including C. diff. You do want to take a culture to determine the culture and sensitivity. You do want to monitor vancomycin drug levels throughout IV administration. You want to use in caution with patients with renal impairment. And then you want to monitor for indications of antimicrobial effects, including reduction in fever, pain, edema, and inflammation. Now we're going to talk about telavansin. Telavansin is the first representative of a new class of drug of agents, the lipoglycoproteins. It's a synthetic derivative of vancomycin. Now, like vancomycin, telavansin is active only against gram-positive bacteria. Telavansin is approved only for IV therapy of complicated skin and skin structure infections caused by susceptible strains of the following gram-positive organisms listed below. The next drug we're going to talk about is aztreonam, which belongs to a class of beta-lactam antibiotics known as monobactams. These agents contain a beta-lactam ring, but the ring is not fused with another ring. Now, aztreonam has a narrow antimicrobial spectrum, being active only against gram-negative aerobic bacteria. Susceptible organisms are listed here on this slide. Now, it's important to note that aztreonam is highly resistant to beta-lactamase and therefore is active against many gram-negative aerobes that produce them. Adverse effects are minimum. This drug is actually pretty well tolerated, but the adverse effects are like those of other beta-lactam antibiotics, and the most common effects are pain and thrombophlebitis from the site of injection. The last drug we're going to talk about is fosfomycin, which is a unique antibiotic approved for single-dose therapy in women with uncomplicated urinary tract infections caused by E. coli or Enterococcus faecalis. Now, this drug kills bacteria by disrupting synthesis of the peptidoglycan polymer strands that compose the cell wall. The most common adverse effects include diarrhea, headache, vaginitis, and nausea. Fosfomycin can also cause abdominal pain, rhinitis, drowsiness, dizziness, and rash. Fosfomycin is supplied as a water-soluble powder in a single dose, 3-gram packets. Dosing may be done with or without food, and symptoms of cystitis should improve in 2 to 3 days. If symptoms fail to improve, additional doses will not help, but it will only increase the risk of side effects. All right, we've made it to the end. As always, if you have any questions, please don't hesitate to reach out to me at dhunt@mccn.edu.